started. For those of you who don't know me, I'm Dr. Rhodes in Department of Radiation Oncology. I'm proud to introduce Dr. John Buatti. Dr. Buatti came to University of Iowa in 1999, and it was the same time I came to Iowa. We both had a whole lot more hair at that point, but we've seemed to have weathered it just fine. He transformed the University of Iowa into a cutting-edge department, and I rely on his resources often. And he's renowned for his work in stereotactic radiosurgery or stereotactic radiation therapy, and it is a program that we have started here and will continue to implement to the non-cranial sites. And he's very intelligent, nice man, and you know, the quality of radiation oncology in Iowa is very very good, and I'm glad we have someone like Dr. Buatti to help us out.
Thank you. All right, well, thank you very much for the kind words, and it's a pleasure to be here to talk to you a little bit about body radiosurgery. And we really are fortunate in the state of Iowa to have a really outstanding group of practicing clinicians in oncology that can talk back and forth, and it's something really as a community we should really celebrate. So with that, let's talk a little bit about radiosurgery. I am going to talk a little bit about the technical details of this and try and keep it at a level to appeal to a broad audience, but if there's more specific questions or things are a little more complex or less complex, or if things are running over people's heads, feel free to slow me down or wave, or we can move things around a little bit. So the objectives that we have are really to go through the basic techniques of doing stereotactic body radiosurgery, and particularly lung. That's probably the most common application. We're going to discuss some preliminary data. We're going to talk about the patient selection, and then we're going to talk about trends, because this field, even though it's certainly being done much more commonly and is getting towards being a more standard realm of delivery, there's still a great deal of data to be learned about how we do it perfectly optimally and how we select patients optimally for this therapy. So if you look at body radiosurgery, this would be a pretty typical example of what you might think about treating, particularly say this person had bad COPD, was not a candidate for thoracotomy, and maybe had a heart attack, and you know this is a lung cancer, you've maybe been able to bronch it. What could you do? Well, in the old days, we might give radiation just APPA, but you couldn't get enough of a dose in to really get good local control. And so the gist of this is that we can now give very high doses, usually in a 3-regimen mode, and get control rates that are in the 90% range in terms of overall control for lesions like this. So we'll talk about how we get there. The second thing that I think this field has really taught us about a lot of radiotherapy in general is the importance of motion. And I'd like to use this slide because even though I'm going to show you how we use this to do targeting for radiosurgical applications, this applies to everything else we treat in any part of the body while we're breathing. And most patients are breathing while we're treating them. And so if you look at the inhale picture versus the exhale picture, you'll notice that a tumor has a certain configuration. And if you took the patient for a planning session like you would for a typical radiotherapy and did it on a non-gated or respiratory specially gated simulation type image, or if you did a diagnostic radiology study, you might well get a picture that looked like this. And you say, wait a minute, if I was looking at tumor response, I'd say it progressed. And this is the same patient on the same day. And the reason is that the patient could be moving into the machine at the time they're doing the scanning, and therefore decrease what it looks like on a diagnostic scan. And this is a big problem for tumor response assessment also. So we have actually some National Cancer Institute funding exploring ways that we can control for this and actually use this kind of methodology for looking at tumor response generally. So I think some of the principles you're going to see in terms of the respiratory gating technologies apply not only to radiotherapy and radiosurgery, but also for just tumor response assessment. So the first thing we have to deal with patients, I like this music, gives everybody a chance to relax. So the first thing is you have to recognize that we're dealing with humans. And humans, if we were to track your breathing right now, are not terribly regular. So what we do is we use this device. This is a respirator. It's actually it's an FDA-approved device for blood pressure. You can listen to this music, and it slowly over time actually spreads your breathing out and drops your blood pressure. So it's used to protect your blood pressure. What we found is very useful to get patients to breathe regularly and at a moderately slow rate. So we just ask patients to breathe in with the tone, and then in with the tone, and out with the tone. And when you do that, probably about 80–90% of patients can do a pretty good job. Because some people, they just get flustered with it, they don't do it. So we get a training session, we look at how that breathing goes, and we'll actually track it with the pictures to make sure that it's nice and even, and then you use it every single day during therapy. So it's an important part of that. The other thing that I want to start with that is that it also shows you that despite the technology, there's probably enough of that music. I haven't numbed anybody totally yet. But if you look at the technology, in a way, I always say that radiosurgery still, for the body and things like lung, is still a little bit kludgy, because we're depending on a cooperative patient breathing in with music like that. We don't totally control that. It's not like radiosurgery in the head where you might have a stereotactic head ring, you bolt them to the table. You have total control of time and space in that model. It's a bolted down type model. In this you don't, so we're trying to figure out ways to get humans to cooperate with what we want the technology to do for them. So that music is an important point. This shows what the breathing patterns are. So this is a respiratory trace if you're just breathing up and down, condensed obviously over a period. But more importantly is this map, which shows the number of times the patients were breathing at a certain rate. So if you look for this individual patient at session 1, not using the respiratory device, you can see the patient's breathing at all different rates. Now, if you try and turn a machine on or you want to optimize it, that's not clearly optimal. Once you do give them the training session, what you're essentially aiming to do is just get them to breathe at one consistent rate so that you can control when the radiation goes into the different areas. And so this was published by Tim Waldron, and he's the physicist that actually helped us design and develop this system. He came up from MD Anderson and was doing it there. So we've used. Then, once you get the patient to go and do that, you need to be able to track it in some kind of surrogate fashion. And we use something called an ANZAI belt. It's really just a pressure gauge belt that has this pressure sensor. And then as you breathe in and out, it creates more and less pressure, and it gives you the sine wave of the breathing. Obviously, this is someone who's perfect. No one here. Certainly not me. If you look at this would be when the machine is turned on. So this system is actually linked to this breathing device, and you can track as it goes along. There are two different ways that people then use this information. So you've got them trained, and you have a trace of how they're breathing. Then what you have to decide is whether you're going to do something called prospective or retrospective gating. Prospective would say, okay, we know the person breathes in this sine wave, and just when it hits this part of the sine wave, I'm just going to take an image then, and I'm just going to give the treatment then. The problem with that is if you look at over the course of breathing, that then is really a relatively short period of time. And so most of the time you're not delivering radiation, so you're less apt to be consistent. Something I didn't say about the breathing pattern before is the longer you have anybody do it, the less likely you are to be very tight in terms of your breathing pattern. So if you have somebody on the table for an hour, it's very hard to get them to be perfectly consistent. If you have them on the table for 10 minutes, you're much more likely to get them to stay with that music and actually do a good job for you. The second way that we use this is with retrospective gating, and this is the way that we practically do it. And the retrospective gating actually uses a model where we use the entire spectrum of the breathing and actually track images at each one and just link the image to that cycle of the breathing. And I'm going to show this essentially in the next couple of slides. So this is the prospective, and so what you do is you just pick this little window in the breathing cycle, and you keep sampling it with your imaging. If you look at the retrospective gating, what you're doing is essentially you're checking one, sampling, you go to another, sampling it, and practically speaking, what we do is usually use 8 to 10 of these windows all together to essentially pull up the entire spectrum of the breathing plane in terms of the images that the patient's going through. When you do that, you get the picture like this we started with, but you can put all those things together and you get a movie loop. And you can see that as the person breathes, you can follow the bouncing ball and basically say, okay, well, now I know this moves up and down. How am I going to turn the beam on so that I optimally make sure that I'm hitting it? Okay, you can't just use a single static set of images. And so what we generate usually is something called an ITV. Now, if I go back, I'll attempt to do this. What you really want to do also is you pick a window that if we're going to treat, so I have all these bins that would be 8 or 10 different things, and I'll say, okay, the person is the longest time in this. In some of these areas around the corners, it's changing more rapidly, so we'll try and pick, say the most common would be the 80% inspiration to 80% expiration, because the actual breathing itself is relatively quick, and then there's a gap in between. So you want to make use of the gap so that you can turn the machine on for the longer period of time possible, and that's known as a duty cycle. So that's back to the movie. So you're going to use it basically so that you're at the longest. You can see it's really down a relatively short period of time, and then you're popping back up. So that's how you pick your windows and you select it. And that ends up calling something from a therapy standpoint being an ITV, or the window through which if you take the tumor volume at the distal end of where you're going to treat to the more proximal one that you're going to treat as it moves. The other thing is I'm showing this in here, I think, 2 dimensions, but recognize these tumors sometimes move in something called a hysteresis type pattern, so it's not necessarily all up and down like this. It can be a little bit to the right or left. It can be a little bit to the front and back. The majority is clearly going to be up and down. But you need to track that and understand it. Once you do track it and understand it, you can start having your dosimetrist and physicists put together plans so that then you can pick multiple different beams that go through and concentrate on treating that lesion. So this would be a typical example of what a radiosurgical plan might look like. I'm not showing you, and I'll show some slides later that show you that ITV area, but you'll actually do that. You'll leave a little bit of a planning margin on it because clearly it's not 100% perfect. You can put something called an MTV, which is essentially the full range of motion of the entire area. But typically we'll use an ITV with a little bit of a planning margin, and then we'll use anywhere between 5 and say 9 or 11 beams to come in at that given target to deliver usually a high dose 3 times, usually every other day, the 3 fractions. And this would, again, in 3 planes, what a typical dose would look like. Then, once you have that all in the planning computer, you have to reiterate the same thing when the patient comes back. So you did all this, you did the training, you went through and did this 4D simulation where you got all that information about the tracking and the belts, you got all that information and all those images that are now thousands of images coming to your dosimetry. You then pick the window that you're going to treat, you've identified the ITV, you've done your treatment plan with the dosimetry, and now you have to bring the patient back and make sure it's going to do exactly the same thing. And so we do 2 things when we put a patient in place for the treatment, and the first is this, which is a cone beam CT. So we use a megavoltage cone beam in the position the patient's treating. Now, one of the advantages of megavoltage cone beam in a way is that it's relatively slow. So it's not going to be as fast as your regular CT scanner diagnostically. So in a way, you're going to automatically see a bit of an MTV because you're doing it over a longer period of time. And so the MTV can be useful for the positioning. So we usually do map an MTV for the positioning on the cone beam. And this shows that with what your planning margin would be around it, and it looks good in 3 planes. And so we say that's great. Somebody's tracking the breathing, making sure that's good, and we say we can go forward and treat the patient with the dose. And that would be the planning scan. Now typically, if you notice, the planning scan, we'll use a free breathing scan and maybe a little bit smaller, and so it's actually bigger on the cone beam than you would see on your typical planning CT. Now, that still doesn't solve it, so now we're going to ratchet it up into a little bit more complexity, because even though we've done all these things, and again, this is part of why I say that the technology hasn't caught up with making this perfectly human-proof, which is what we'd like to do. We'd like to really control where the beams go at all time in the patient. So one of the problems you have is, even in the best-case scenario, you've trained the patient, you've gotten them to breathe. You know that when they come in different days, they may breathe a little bit deeper. They may be a little more out of breath, and so that breathing pattern isn't exactly the same. And so what you're really doing, I went through the last one kind of quickly, is you can get this information. If you think about the cone beam CT, you can take all of the information you got from all the different couch angles from the megavoltage cone beam and essentially make a real-time movie loop of the port films as they went around, because really that's what a CT is, right? It's a whole series of different radiographic images from all the different angles, and so you can actually reconstruct the motion for that given day, and that's what Alf Ciocci has done in this next scan, and this shows for 2 different days, one where we picked a gating window in the top where we put these little markers post fact on the diaphragm, and you can see you can track the diaphragm, and it's within this window of the blue and green. On a different day, the patient came in and was breathing, and they were breathing a little bit deeper or shallower, and even though your respiratory trace may be in the same relative place in terms of tracking relative effort, it's not giving you a pure effort or depth. It doesn't necessarily exactly trace to what's in the patient at that time, because these things are all surrogates, so they're not accounting for different efforts on different days. So we're working on ways where we can actually track the effort by virtue of using real-time cone beam CT analysis of the projections to tell us where the diaphragm are, so that then we could either correct the breathing or only turn it on when you're within these limits at the time of treatment. Or at least you know they're breathing similarly that day than you would. Or you could say, I need a little bit more margin on that given day. And this basically explains more about how that would go. In the given window, you'd get a different amplitude, so we need a real 4D verification model on a given day. And this shows essentially how that could be. You basically, very similar to the trace you get with the surrogate marker in terms of the ANZAI belt, you'd use the diaphragmatic spot to generate a very similar loop and make sure that they're actually matching up in terms of amplitude. So one would come from the ANZAI, one from the other, and you'd make sure that they match. And then you could actually have good correlation of the window from that. Or on a different day, they're breathing significantly differently. You could see that amplitude and potentially correct for it. So you could do adaptive breathing for that patient. You could ask them to either breathe more shallowly. Again, you could theoretically open up the window. So we're working on ways to implement this practically in the clinic, but you can see this is quite a bit of information, again, on a real-time basis on the treatment machine for these patients. And this shows the correlation of the diaphragm with the actual tumor motion. So we track that out with the cone beam also, and it does track together. That's the key there. This is the amount of motion. I don't want to get into too much detail on it. The other thing that we think is interesting and will be important is there's an increased move towards using PET imaging for the treatment planning techniques. And there's no reason for us to think that PET isn't also influenced by respiratory movement like regular CT imaging. but it's probably a little bit different, because what happens with the PET, if you think about it, is as emitting from the given tumor. As that tumor moves, areas where it's in the same position or where there's some activity emanating from one position is going to be relatively bright. Things at the end are going to end up blurred on your PET imaging. So you can get a larger than you would think image. And so you can optimize this with the respiratory gating techniques also for your treatment planning. And we've done some respiratory gated PET imaging. So we can get not only a 4D PET, but we can get a 4D CT. We can also get a 4D PET to track with that and theoretically do that as well. So the clinical process for this real-time verification is the registration of the megavoltage cone beams, drive the motion, basically calibrate the strain gauge so that it's accounting for the relative effort, and then you could determine the triggers so that it really does match. Another opportunity, and we were talking a little bit with one of the physicists this morning about this, is basically using linear accelerators without a flattening filter. For so many years, most of my career, flattening filters were an essential part of any accelerator. It made sure the beam was smooth across a relatively large plane, but if you take it out, you can get a lot higher dose rate. Well, I've told you that the amount of time somebody is on a treatment table means their breathing is going to be more or less normal, and it's harder to predict the longer they're in a position. So in theory, what you'd really like to do is know exactly where something is at the point and go boom and put all the radiation in. Problem is the machines aren't that fast. So a higher dose rate, in theory, should be able to deliver all of the radiation in a shorter period of time, and you're more likely to have that control over that shorter period of time. So you should be able to be more accurate and more efficacious in terms of your radiation delivery. And we use a machine that does have this, about 2,000 monitor units a minute going in. There are some theories that the biology of this may be somewhat different and may actually be more efficacious for the tumor, but that's not fully worked out, and there's data on both sides of that fence. So I would not take a position on that. I don't think we know. This shows the amount of reduction in treatment time using the high energy beam versus not. So the high output machine versus not. So it's the same energy, just different output. So you can see you can save about 60% is the bottom line in terms of your treatment time by removing the flattening filter and delivering your radiosurgery with that, which is significant. This is another example, again showing this MTV versus ITV difference. Again, smaller. Another important thing to realize is that tumors change over the course of therapy, and this is if you're looking at motion, the motion of the tumor to what's happening can change. And so, again, if we don't routinely monitor this through a course, I think we're more apt to get burned. If we're doing 4D, say, in a more extended course. In a 3 course over 1 week, you're probably less apt to run into this problem, which would be an advantage for radiosurgery. But if you're spreading out any longer than that, or if something changes, you really would like to be able to get a handle. And so if you look at the tumor size and position from day 15, we have a planning scan there and here. And what I want to highlight is what ended up happening with this tumor. It was kind of tethered, so it was moving differently than it did relative to day 15. So you can see there's the shadow over here from one scan superimposed and the rest on the other. And it wasn't moving this way when we did the initial 4D scan. So there's more adaptation as we get more imaging through the course of therapy. If you're using a small window, I think you have to really be attentive to even daily changes in terms of where these volumes are. So I'll get to at least a little bit of data. So from my perspective, radiosurgery, having really done a lot of intracranial radiosurgery since the early 90s, and seeing how that field has evolved rapidly in terms of being a very standard techniques, you have to recognize that radiosurgery intracranially has more than 50 years of experience. If you look at really stereotactic body radiotherapy, that period of data collection is very, very small, and it always starts, exponentially. You start with a few places doing it, a few more places doing it, a few more places doing it, and so that data is not nearly as mature. And so what I'm going to do is try and show a couple of case examples and show what data I think that we can pretty definitively say from at least the best data that we have available. I also think it's important that we not just say, well, if you look at the literature, this didn't work or that didn't work, because the techniques have changed. I've given you a pretty detailed discussion of a single technique of actually how to give radiosurgery, but there are tons of other ways that people have tried to tackle this. A lot of groups have tried to use compression things, and we're going to limit the motion. There are groups that have used things like anesthesia and jet ventilation to actually try and control. Let's just make it not move. We'll use a jet vent. I mean, that's at another extreme of this. There are people that use visual cues. So rather than the music that I showed you, they may have something in and out. There are other groups that have tried to use breath hold. What we'll do is we know the thing may not move as much if I just have you taking a deep breath, hold it, we'll verify where it is and quick give you the radiation. Okay, that again, you can imagine that being included. There are some things that have valves, so you're going to try and limit the degree of amplitude change you get between days by using a valve that can control some of that. So if you're looking at all these techniques, it's hard to generalize and say, well, here's the results with radiosurgery. It's not like radiosurgery in the head, where actually there was a big dispute, well, it's gamma knife versus non-gamma knife. This is far more complex than that. All these things are really being done with linear accelerators, but some of the techniques are very different. So the key thing is you do as best technique as you can within the physics constraints to get as accurate as you can. And I think it is getting better, because we're learning a lot about how things move and how to more optimally deliver the therapy. There are some very important dose escalation studies that have been done. Bob Timmerman group at Indiana really, I think, pushed the envelope on this, and have shown substantial local control in very poor performing patients. And they did classic phase 1 dose escalation type studies using 3-fraction regimens, moving up from about 10 to 12 gray and taking it up into the 24 gray times 3. Which, if you think about from a dose standpoint, is really an astronomical dose compared to what you'd deliver with a fractionated standard dose. And I think the early studies, without question, are very, very promising in terms of control, in terms of potential input for future care of patients. The first studies, and who should you select for these? And the initial studies were really restricted to patients who had that T1 pretty small tumor in a patient that typically would be treated best in conventional manner with a thoracotomy and get a complete resection, but who might have horrible FEV and pulmonary function and so weren't candidates for that, or patients who maybe had horrible cardiac disease and therefore couldn't have it, and it was limited just to that subgroup. As the results came in and they said, well, look, the control is very, very good. It's more than 90%. It seems those patients are doing almost as well as the surgical patients. People started asking, can you broaden it out? The logical questions, well, can I treat bigger things? Oh, could it be an alternative to surgery? Then it becomes, can you potentially treat other things, metastases, things that, might actually be useful, or the people are having control. And then if it's metastases, well, then it becomes, well, how many? And then it becomes, well, where? And then how do you integrate that into the fabric of oncology care as a modality that really enables you to deliver a very focused dose of radiation to a particular lesion and avoid most of the other tissue. It really, I think, changes the game. It certainly changed the game in the brain, and there's no reason for me to think that wouldn't be exactly the same case in terms of the rest of the body. So I think we'll see more extracranial radiosurgery of the lung as well as other sites as the field progresses. and you'll see that it becomes really a new standard for managing many, many things. Not everything, but a lot of things. So we'll talk a little bit about some of the specifics of the early studies. If you look at early lung cancer treated surgically, patients who were surgical candidates, the 5-year survival rates of 45 or so to 77%. It's a very good local control. It's why it's the preferred option. There was no standard radiotherapy that would get you that kind of overall results. If you look at the RTOG study, 60 gray and 3 fractions, I'm going to point out to follow, that's probably really about 54 gray and 3 fractions because this didn't use something called lung corrections. So we know that if you don't account for the difference in densities, it looks like you're giving a little higher dose. It's probably about 54 gray and 3 fractions if you account for those differences. And if you look at in these medically inoperable, poorly performing patients with small lesions, you ended up with local control of 98% and local regional at 87% at 3 years. So very, very equivalent. And the survival is 56%. So it's right in the exact same range. This was that initial study, 59 patients, T1 and T2 lesions. Again, a little bit different. The motion and the actual quality control was pretty broad. They wanted you to use compression. They wanted you to have some kind of fluoroscopic imaging. It wasn't controlled in terms of doing 4D, how much margin you left. So these, this initial study could even be better than the results reported, but I think it at least gave you a sense of, those doses can take care of it, and so long as you're leaving enough margin, it's probably safe. As you get to bigger tumors, you probably have to be a little bit more exacting because you don't have as much wiggle room as you have a small lesion. You can leave a little bigger margin. There are definitely toxicities. I think the one everyone would expect to get some pneumonitis. No one knew would you get a lot more pneumonitis giving these 3 doses of very, very intense radiation, or would you get less, or is it more a volume effect? I'd argue it's probably more a volume effect because that rate is pretty small despite giving a very, very high dose of pneumonitis. There's about 4% had worse breathing. Again, this is in a group that's a poor functioning status to start with. The one toxicity that I don't think people necessarily knew would be there are not as chest wall. So I think now almost everybody doing a lot of lung radiosurgery is very careful about the chest wall and what dose it gets. If you're upwards of about 15 gray per fraction, you have a pretty significant increased risk of getting chest wall toxicity, being chronic pain, could be fracture. A lot of the patients we've had when we've shown them to radiology, you can have little microfractures in some of the bones along the ribs. Now in the long term, if you're really trying to control a cancer, some of that's a trade-off, but certainly it's a toxicity that I think delivering this therapy you have to be aware of in terms of what your chest wall dose is. Maybe not a lot of skin reactions, but still the chest wall and chest wall pain. So a possible toxicity, not very high, but I think as we learn more, we're going to be more conscious of it as we deliver the therapy. Again, very similar results. The current study from the RTOG that expanding is really to randomize patients who would have had surgery. So now the question is, can it serve as an alternative to surgery in selected patients who would have thoracotomy? This study is currently accruing. It is using 2 different fractionation schemes if something is closer to the central area or central vessels. Most people don't want to give 3 fractions to that because the risk of potential damage might be higher, and obviously it would be more devastating if you got a central injury to a vessel in the lung. What do we do at the University of Iowa? Our standard regimens pretty much are, if it's a peripheral lesion, pretty small T1, T2 lesion, we probably use 18 gray. If it's a little bit bigger, then we'll use 16, maybe a little bit lower than 1. If you look at lesions that are central and are right against a vessel, then we'll use 10 gray times 5. Going forward. If it's maybe you think a little more wiggle room, you can use 12 times 4. And these are pretty much standard and very consistent with the RTOG doses. I can tell you that, at least in our experience so far, they seem to work. We don't have enough patients. I think we can do as good an analysis as the RTOG, but it seems to be consistent in terms of our initial experiences with this. In terms of, I'm going to give a couple of examples because I think it points out some of the potential for the technology. And these are the kind of cases that, at least in my experience with brain tumors, are very, very analogous. And one of the things that I remember, and I think most people should remember, is training. And Joe can certainly identify with this too. It was a very simple. I always like to use the example. It was a very simple paradigm when I was training for brain metastases. It was brain metastases, whole brain radiotherapy. That was it. And essentially 46 months survival. There weren't choices. That was it. It was just about what we had as an algorithm. Then people started doing surgery. Well, if you had a single met, maybe if you cut it out, and then maybe you don't need to give the radiation, or maybe you do. Well, you found out that, one, if you did surgery and you removed it and gave radiation, you had a percentage of those patients survive 2, 3, 4, 5 years. So there was actually a small group with oligometastases that were curable. Then, to make it a little bit more complicated, people started saying, well, if you have radiosurgery and you can give this new treatment, much like I said with the lung, you can treat a small lesion, you can control it 90% of the time. Well, maybe we could treat 2, and maybe we could get close to that. And you probably don't do as well with 2 or 3 or 4, and there's probably a limit. But it's very clear. I have patients that had 2 or 3 brain metastases that are alive 7, 8 years later. And why? I don't know. But I do know that we treated them with very small fields, maybe now eliminated the whole brain radiation, and there's a population of maybe 10 to 20% that you can get to a much longer survival than you actually looked at. Now, that's a real change in terms of overall management that translate into a lot of good years of life for a lot of these patients. So I think in the body we should be thinking about this, and then how we interdigitate it with our medical oncology colleagues who right now, patient has a few lung mets. I think the most standard approach is, well, they need chemotherapy. Well, clearly they probably do if there are other microscopic lesions, and they're a high risk for that. But I think that there's a real role for maybe doing spot treatment if they have a limited number. And then with the chemotherapy, you may get a better long-term survival. So this is an example of a fellow I treated back in 2006, I think, was the first time I treated him. But he essentially came in with hepatocellular carcinoma with a single lesion. He got chemoembolization and had a liver transplant. And it wasn't much after that he came up with 2 lung nodules. So with 2 lung nodules, they said, well, we'll resect them. They wanted to prove they were hepatocellular cancer. So they resected both of them, and within about 2 months, he came up with a new one. So I was asked to see him, and I said, oh, this seems like a good potential. He only has 1 little lesion. He's HCCs just through a transplant. We'll see if we can do radiosurgery. So we did, and we gave this 24 gray in a single fraction to that lesion. Now, I was coming more from a standard radiosurgery background where you gave single fraction, and this was very tiny. I thought it was a good idea. And I did that, and actually the patient, very soon after that, the AFP started rising again, and the lesion really didn't look like it had gone away. Maybe it was a little bit bigger. So the surgeon said, we just better take that out. And they took it out, and there was still viable cancer there. And so shortly after that, 4 new lesions came up. Okay, at that point, I wasn't very enthusiastic, but they said, well, maybe we could add chemoembolization. And so they added chemoembolization and asked me if I could consider radiosurgery. And I said, well, I know the 24 and 1 didn't work. I know he's got 4. He doesn't have anything else as we can tell in the rest of his body. And so I treated basically all 4 lesions, 18 gray times 3, 54 gray. You say, well, this is really stringing on. You're just a madman. What are you doing? And it's only a couple of months after that he came and he had 1 single lesion right against the mediastinum. His AFP was still staying up, so we treated that lesion 10 gray times 5. Now, the interesting thing with this fellow, for me, is that after we did this treatment, and we'd gone through all this, so now treating 5 different lesions over time, he remained disease-free with no evidence of recurrent disease for about the next 3 years. Okay? Now, I don't think most of us would say, oh, that's what we thought would have happened, okay? Because it's not, but I think the lesson, at least for me, as we manage these patients, is if people have limited bulk disease and do it, there's a population that if you're rigorous about controlling small local disease, you can really temper out for a substantially longer period of time. And this person did not end up getting chemotherapy. They were a little bit too ill. So there's those with oligometastases, and in this case, it was probably about 6 or 8 lesions that maybe were micrometastatic, and the rest of the disease was gone. So again, very telling case. And I have other cases like that with 1 or 2 lesions that are colon cancer, other sites like that. So I think we should think about it for oligometastatic disease. This is another unusual case that I always like to use because, again, it shows you thinking outside the box can actually be a little bit helpful. So this was a fellow who came to me about now 4 or 5 years ago. And he was an elderly guy, 93, and he's still alive now, so he's about 98. And he had horrible heart disease, had horrible medical function, and started getting a hypercalcemia. He had a parathyroid hormone of over 250. He had a positive sestamib scan, and they sent him to every single surgeon, said no. I cannot touch this. We had him see our surgeons. They saw the local surgeons. This fellow was actually in Waterloo area. They even said, well, can't we do it under local? And they said, no. This guy, he's horribly kyphotic. I wouldn't even think about doing the guy under local. So he had this lesion that you could see on CT scan and correlated with the sestamib scan. And I treated this in 30 gray and 1 fraction 5 years ago. And the interesting thing with this case is that his calcium normalized, went down, and we haven't had to do a thing. He had no toxicity from this. I mean, he didn't even complain of sore throat. So I would have thought he would at least had a little bit of sore throat. But for a guy to get 5 years out of it, so I think, again, as we have these technologies available, we really need to think about using radiation therapy in some different ways that I think can be helpful to everybody. Again, summarize, I think I've talked about a lot of these issues in terms of going. I could not get through a talk with Elise talking about some of our other research. This is some work that our physicists are doing. I think this is stuff that, this is what floats my boat. I'm kind of a nerd, so I'll fess up. So this is some stuff they're doing with the biomedical engineers, and Joe Reinhardt's the chair of biomedical engineering at Iowa. And we're looking at doing lung function based on 4D CT. We've got all this 4D CT information now, so we get the full range of the respiratory motion. And what you can think of is each voxel, as somebody breathes, it changes, right? So it's either getting bigger if they're breathing in, or it's getting smaller as you breathe out. So as those voxels change, and I'm not going to go through the math, but you can see a whole bunch of formulas. You can actually mathematically define what those expansions and contractions are from a computer engineering side. And then if you put them all together, you can actually develop a scheme of expansion and contraction from a color map. And you can correlate that with the pulmonary functions. And you can not only correlate it with their pulmonary functions, but you can correlate it by regions. So in this slide, what I really want to look at is in the first, this is pre-radiotherapy. You can define areas of lung that are actually very important functionally and areas of lung that are less functionally important. So the blue and purple are basically the more important functional lung. Not surprisingly, you got this tumor in the background of the CT. It's not functioning very well there. Then after RT, you can see, not surprisingly, you actually do a little bit better in the lung where we did some radiation. So this is actually a change map where it goes. The lesson here, what I think is intriguing, is that it's not just what happened in the radiation field. So if you look at actually the change map in the contralateral lung from where we treated, even though this was the radiation field, the contralateral lung had quite a few areas that actually decreased function after we gave the radiation. And I don't think that's scatter, because our standard thinking about lung toxicity and radiation is that it hits what it hits, but there's probably a more complex dynamic. Some people think it might be lymphedema that's happening within the radiated lung that then spreads to the opposite lung so that that function could go down. Others have thought maybe there's a mechanical mechanism that actually could move this. And so I think the interesting part to me about this is it raises two really important points in terms of how we think about radiotherapy in the future. One is if we look at lung function, we might be able to segment it into different areas and pick radiation beam paths that go with better functioning lung or worse functioning lung, so that in fact you might be able to get more radiation in by using less functional areas to start with and still preserve good function. And it may be that in certain constellations you have a risk of damage to the opposite lung. It could be, we don't know if it's volume effect, but as we study this, we'll learn there could be other strategies that we might want to use that would affect how we bring the radiation into these areas. So I think it's an interesting area that we have some R01 applications looking at and some preliminary funding. So that's about where I end. The conclusions are essentially that radiosurgery, I think, hopefully you'll appreciate, at least to me, coming from a radiosurgery in the brain, I think this is way more complex and involves an interaction of a really detailed team to work with the patient for training aspects, to work with the physicists in terms of the image acquisition, that are many more images and more complex images. I think the setup and the verification becomes more important as we add the complexity to it. And I think really, even though we have those simple schema that I showed with the 16 and 18 gray and 10 and 5, I suspect that that's not fully defining the toxicity risks for these patients getting that therapy. Much like in the brain, we know there are certain areas of the brain that are more sensitive than others. I think with a functional lung, we're going to know that some areas are more sensitive than others, and we may actually have to change how we use those doses in categories based on lung function. So I think that's the area. And then I close. Where's my? Oh, I thought I had my last slide. Nope, I don't have my last slide. All right, close there. I'm happy to answer any questions, even trick questions.
Larry Ottoman, I'm a medical oncologist, and welcome. Thank you for speaking. Moving the beam to correspond with respiratory movement, is that possible?
So yes, there are groups in the country working, and so what you're talking about, the way we currently use it is we do gating. So gating is essentially you turn the beam on and off when it's in a certain area. In theory, you could use the multi-leaves and get them to move back and forth with it as it moves. The problem right now is computer speeds. So the computer speeds to actually get those leaves to move in sequence fast enough to track effectively is not completely worked out well. Like always in my career, I've never seen it where computer speeds didn't get faster. I suspect with time that there will be solutions that are actually very, very deliverable with that.
That was, as God is my witness, that was my question. I have friends in Hollywood that do things with graphic design where, they can track an actor and put in an animated actor, and I figured,
yeah.
So they're working on that sort of thing.
Yeah. No, it's really interesting stuff when you can track.
Thanks for the presentation. That was great. Just a question about fractionation choice. With the RTOG, they did 20 times 3 as their standard arm, but they also have done 12 times 4, and they don't divide it the way it looks like you've divided it. Was that because of chest wall toxicity? Do you think that they changed that as the standard arm, or what's the rationale for making that the standard arm?
Making 20 times 3?
No, they the more the RTOG trial that has 12 times 4 as the standard arm in comparison.
Is it? Actually, maybe they did that, or maybe they were allowing larger lesions. So I can't answer that, but I don't think the 12 times 4. We're certainly comfortable, but if something is near the periphery, then I'd use 12 times 4. I certainly wouldn't use that as the standard arm.
And they also have a trial that's a single fraction, and I take it from your discussion you're not in favor of a single fraction.
I've used single fraction, and unfortunately, all of us get a little bit jaded by our initial experiences. And I used single fraction on a number of people, 20 gray or 24 gray, which I thought was pretty robust, and it really didn't do as well. Now on the parathyroid case, I used 30 times 1. Seemed to do well. So, and I extrapolated that from basically pituitary data where we treat growth hormone secreting tumors 30 times 1. So, I guess right now, I think there's more literature with the 3-fraction regimens. There's enough differences in motion that between the two, I'm probably leaning towards supporting the 3-fraction regimen, even though it's very possible that somebody can come out with a single fraction regimen that's just as good. But it's going to take study, and you're going to have a real detailed toxicity study. But the data's not there. That's what's hard about it. Oh, yes. Yeah. Yeah, so usually, we're aiming for about 16 breaths per minute, okay? Somewhere between 12 and 16. You don't want them too slow because then they have trouble with it. So we try and train it into that range. Again, everybody's a little bit different, so you have to know what your patient's feasible of, and that part of that training interaction is really important on that. From a margin standpoint, we usually use the ITV, and then we're adding about 3. Yeah. Yeah. The other thing that does come up, another common question to think about is, we've raised the question sometimes, when do you not need to gate? Because, we know some tumors move 2 centimeters. Some tumors don't move a whole lot at all. If they move 5 millimeters, do I need to gate at all? And for the radiosurgery things, we usually are gating everybody just to be sure that it's there. With the fractionated regimens, usually if they're less than 5, then we won't gate. Thank you very much. Thanks for inviting me. You want to know?
Well, I actually was just going to ask a little bit about more about the gating and abdominal compression and treating the ITV. You don't do that.
I don't like abdominal compression.
Okay.
So I'm a firm believer that if you make a patient uncomfortable, okay, you will have them move more. So if you put a compression and you're not going to get that perfectly the same, and if I ate beans for dinner last night, I'll be more uncomfortable today than I was yesterday. And,
Just the variability.
And then that translates and that whole respiratory thing changes. I think let people lay down and be comfortable, and then try and sort out what you need to do to make sure that you're tracking it. This whole pushing, and unless you can truly do like the head and nail it down, which you can't do with this.
Okay, thanks.
Yeah.